Well, good morning, everybody. This is my great pleasure to present our today's speaker, Dr. Leslie Cooper. For many of us, he doesn't really need an introduction, but he's the Elizabeth Lane and the Dean Zimmerman Professor of Internal Medicine. He's the former chair of the Department of Cardiovascular Disease at the Mayo Clinic in Florida. And he also served previously as the director of the Ganda Vascular Center at the Mayo Clinic in Rochester. Since he has some personal relationships here within our, MHI group with Dr. Skake. I think what's most important is that Dr. Cooper has been the mentor, an incredible physician to so many. His main interest in terms of research and translational studies includes inflammatory cardiac and vascular diseases, giant cell myocarditis, cardiac sarcoidosis, eosinophilic myocarditis. He probably has heard about at least 80% of all the sarcoid patients that went through Minneapolis Heart Institute since 2010. That's when I joined. And really has been an incredible mentor to me and many other colleagues. He serves as the international editor of the European Heart Journal, cardiomyopathy section, editor of JACC, heart failure, and on the editorial board of Circulation Heart Failure. He also founded, and I asked him, what are you most proud of? And he said he also founded Myocarditis Foundation about 20 years ago. That's been incredibly active. And I said, I think we need the whole ground rounds to hear about it. But with thousands of patients being enrolled every year, also grant opportunities, so extremely active in that field. And then when I was just reading, he's a native of Philadelphia. He said he didn't like Philadelphia. So he went to Boston, he went to Harvard, and from Harvard, he went to Stanford. And then he slipped a little bit because he did his residency and fellowship at USC. And then joined the Mayo Clinic in Rochester in 1997. So we're incredibly grateful you're here. Thank you so much. And I also wanted to acknowledge our exhibitors today, Amgen Cardiovascular and Edwards Life Sciences. We're very grateful for your support. So thank you.
Oh, Kasia. Well, Kasia, thank you so much. It's such an honor to be back here. As Anita pointed out, I gave grand rounds here 10 years ago at his invitation, and it's changed. You have a whole new building and new faculty and staff, and it was just so cool last night to be able to go out with your faculty and talk about our cases and our common interests, and today to spend the morning with you. So we're going to start this morning with a 40-minute talk, questions and answers, and I'm here. If any of you have the time and interest, I'm more than available to talk about either cases or research, whatever you would enjoy. And so in the next 40 minutes, we're going to talk about this update on myocarditis management. It's a very clinical update, although I've spent a lot of my career doing translational science with a number of wonderful partners in mouse models and kind of mechanistic studies. This is all about clinical management today. And the framework we're going to use is a comparison of the European Society of Cardiology 2025 guideline on the management of myocarditis and the parallel document from the American College of Cardiology, which is the Expert Care Decision Pathway, EDCP, which came out in February of last year. And so I have a number of consulting and other relationships that aren't really relevant to our topic today. So if you missed it in August 29th in Madrid, the first guideline on myocarditis came out. There was a 2015 guideline from ESC on pericarditis, but this was a 10-year update of that and included myocarditis. We'll go into that very important document, 90 pages. We won't have time for 89 of those, but we will cover some of the highlights as they compare and contrast with the US paper. This is what we wrote. I was one of the chairs of this committee, and we spent 2 years really a lot of diligent effort and a lot of reviews on the current diagnosis and management, very clinically focused with pathways that you could use today in the hospital and the ER. And so we're going to have a couple slides on epidemiology that are in press right now that are coming out from the 2023 Global Burden of Disease Project. Talk about how the ESC and ACC classified myocarditis a bit differently. We took different approaches, but they're I think, complementary. And then very practical, how do you make the diagnosis? When do you do an MRI? When do you need to send for a biopsy? And then the therapeutic strategies. We're only going to have time to focus on a select group of specific disorders, cardiac sarcoid, for example, which has been an area that we've worked together on multiple patients, Kasia and I, as well as giant cell myocarditis and a few other specifics. There are some new things. If you're not a cardiac pathologist, you may not have read about the Seaport criteria, but just a show of hands, who has heard of the Dallas criteria? Oh, excellent. So half the room. So the Dallas criteria were written in 1986 for the US myocarditis treatment trial and became a standard clinically for the pathologic diagnosis of myocarditis. The Seaport criteria, named after Boston Seaport, where one of the meetings was, is replacing that, hopefully, and that came out in September. Then there are a few other topics listed there that we'll cover. So this figure is from a paper under its second level of review now at JACC, which shows the 2023 global distribution of incident cases of myocarditis. And it's important to realize that most myocarditis, what this really illustrates, gets better. The average duration of myocarditis is maybe 3 months or even shorter in mild cases. And so the prevalence is much lower than the incidence. And you'll notice that the color here in North America and Western Europe is different than in Africa and South America because I would say most of the high socio-demographic index countries, SDI, have access to biopsy and MRI, where those technologies, which are the pivotal tests for diagnosis, are simply not available at scale in other countries. So the diagnosis becomes dilated cardiomyopathy or chest pain with normal coronary arteries. Overall, about 1 million cases in 2023 with a relatively low overall mortality. The distribution is very different. You can see here, this is ages on the x-axis less than 5 to age 95. And you can see there's a big bolus here in the after puberty. Once teenage hormones kick in, there's a rise, and the rise is greater in males than in females. Blue bars versus the red bars for male and female incident cases. But then at menopause, right about here at 55, the sex difference disappears and goes down. So that's the real take-home point. Most myocarditis is in young people, and it's pretty mild. Chest pain presentation, normal ejection fraction, no arrhythmias. But in the older group, as we'll see from subsequent data, that's where you see the checkpoint inhibitor myocarditis, more of the giant cell myocarditis, more of the drug-related adverse hypersensitivity reactions. And so the severity is both because of the nature of the disease and because older people have less resilience than younger people, the mortality goes way up. So this is the mortality figure, and it's quite dramatic. Children under age 5 who have relatively immature immune systems, and this is now being modeled in animal models as well, have much higher rates of death. If you look at neonatal myocarditis, very high rates compared to the children who are older and teenagers. And it's really here about age 60 that the death rates take off. And I think that's due to a combination of different causes as well as just the older, lower resistance in that population. So let's start with, this is part of the central figure from the ESC document. And the key take-home point is IMPS, that there's a spectrum, not 2 separate diseases, but a spectrum from pericarditis to myocarditis with the middle part called myopericarditis, where you get a pericarditis like chest pain syndrome with elevated troponin, and that's maybe 15 or 20% of pericarditis. It's important when you see your pericarditis patients in the ER, and it's like, oh, diffuse ST elevation, PR depression, I got this right on the boards, I know what it is, to remember to get the troponin, because that will affect your return to play perhaps and your follow-up. In both the US and the European documents, acute is now defined as less than a month. That's been pretty standard for a long time. And chronic is now standardized between both ACC and ESC at 3 months. If you're into this, historically, 6 months used to be what we called chronic, and it's been slowly moving up so that now And that's important because of design of clinical trials and how you read the literature, that a lot of the older stuff from 2015 and before really required 6 months of stability before calling chronic and being able to enroll in studies. It's important to realize that 6 to 14% of people in large registries have recurrent myocarditis or pericarditis. Has anyone used rilonacept or Arcalast for pericarditis? Show of hands. How many people have heard of Arcalast? Show of hands. Oh, most of the room, good. So IL-1 trap or inhibitor, and that is used for pericarditis right now, but it is, we have a very similar rate of recurrence in myocarditis. So in contrast to the ESC document, the ACC group, and this was actually proposed by Beacom Boskert, one of the other chairs, she wanted to take the heart failure paradigm of stage A, B, C, and D, which we're all familiar with from decades of at-risk, asymptomatic, symptomatic, and then end stage. And the reason she wanted to apply this, and I think it was a good idea, and it's the same idea in a different way in the ESC document, was that it raises awareness about early myocarditis. So for example, most checkpoint inhibitor myocarditis is simply an elevation in troponin without a clinical syndrome. Depending on the severity of the elevation, there's a different prognosis and risk. But if you're not thinking about it and you don't check a troponin, you don't pick up on the group that needs triage, right? So this, I think, was a very good thing. And I'll go over this in specific examples here. So who would be the people at risk that you'd want to screen? Well, both the US and European guidelines and scientific statements for checkpoint inhibitor myocarditis recommend screening in the beginning after the first few cycles with a troponin and EKG. Both the European Respiratory Society and the American and Canadian Heart Failure, HRS, Heart Rhythm Society, recommends screening systemic sarcoid with at least an EKG and clinical exam, and in the US with an echo. Clozapine, I'll show you a paper from March of 2025, which was from a Delphi process that I was part of, recommending screening with EKG and troponin for the first 2 cycles, first 2 months of, first 2 weeks, excuse me, of clozapine. And then there's the area that we don't know about. For example, is there a role to screen or think about myocarditis risk in people who are gene positive? On the drive over here with one of our fellows, your fellows, we were talking about a genetic risk and his interest in that area. We have a paper that's under review now, the UK Biobank, of 100,000 people who were all genotyped. And those people who had positive pathogenic or likely pathogenic variants had a higher risk of myocarditis 2 to 3-fold in a population-based study. And then we all remember SARS-CoV-2 well, and the vaccine risk in young males. This is a figure from the British Journal of Psychiatry just illustrating the recommendations for EKG and troponin screening for the first weeks of clozapine use. It's just an example that you may not run into every day, but the rate of myocarditis is about 1 in 1,000 in this population who are starting clozapine, and the mortality, if you get myocarditis, is upwards of 25 to 30%. So again, a rare event, but you should keep it, always think about it. Stage B are those people who were screened at stage A and found to be positive. And as you well know, a positive troponin in a cancer patient could be a pulmonary embolus. It could be an MI. We live in an ocean of coronary disease, and myocarditis remains the rare tigerfish or whatever in the ocean of sea bass. You can tell I'm living in Florida now. I didn't say walleye. So management depends on context, of course, and we'll talk about that for specific things. Now, one thing that's new is that both now the European and the US documents recommend cardiac MRI as a pivotal diagnostic test. Historically, the European documents said you needed a biopsy, even in the mild cases, and that is now aligned. Both documents say the same thing pretty much with the same language. There's a class 1 recommendation, level of evidence 2A. For us, I think they have a level of evidence, might be, I think it's still 2A, for the European document for Lake Louise criteria. So we wrote these. I was on Lake Louise 1 and 2, and we wrote them for viral myocarditis, acute viral myocarditis. So we never intended this to be for sarcoid, which is kind of a chronic recurrent process, or the chronic inflammatory cardiomyopathies, which the Europeans write a lot about, which is more 3 months or more of recurrent myocarditis. But it was intended for acute. It's meant to be 1 T2 and 1 T1 based criteria that are positive. It's been extended, and it's been 8 years now since this came out, and strain imaging has taken off, and a lot of other things that MRI does well, layer-based strain imaging, which has both diagnostic and prognostic value. So I think we probably need Lake Louise 3. How many people do imaging here? Oh, a handful. And do you use Lake Louise criteria when you diagnose myocarditis? Yeah. So again, it is funny because we really were not, there was no checkpoint inhibitor myocarditis. Obviously, COVID hadn't happened yet. So a lot of this got applied, I'll say perhaps correctly, I don't know, to a lot of diseases that didn't exist or weren't ever discussed at our committee meetings. So when should you still do a biopsy? So both the US and the European documents recommend that biopsy has a class 1 indication for people with new onset cardiomyopathy complicated by symptomatic or sustained ventricular arrhythmias, high-grade heart block, or failure to respond to guideline-directed therapy in 1 to 2 weeks. And so that's about 10 to, depending where you work, 10 to 20% of myocarditis. It is important because of that group, 20 to 25% will have a specific histologic form of myocarditis, like giant cell or eosinophilic, which is hard to tell, really, I think perhaps very often not possible to tell from MRI. Indeed, I just, coming here on this trip, got an email from somebody who had the mother of their daughter-in-law wrote, because they had passed away, of giant cell myocarditis with a normal MRI. So it's rare, but it does happen. You get normal MRIs and even normal troponins. So this is the figure, that what I showed you is the ACC figure. The Europeans have better artists. And so they got this really nice gradient color figure instead of the little box figure we got. But it says the same thing a little bit more elegantly, and that is that if you, after you exclude coronary disease in both algorithms, then you get admitted, and you have to triage. And this is intuitive here because you're sophisticated cardiologists, but it's not intuitive everywhere. That if you're at a small community hospital in the rural Minnesota, do you transfer to Minneapolis Heart or Mayo, or when do you make that decision so you don't transport on ECMO in the middle of the night, right, which you want to avoid. So decide if they're in early shock or not, if they're getting arrhythmias, and then go to a unit that can handle that with transplant capability, and then there's a class 1 indication for biopsy for them. And then if you are stable, all the chest pains, all the normal EFs, the people who have modest elevations in troponin, all those people can get an MRI within the first 2 to 4 weeks. So alignment. I threw this in because I think this will be a thing that you'll hear talked about. You may not touch your life specifically, but if you read path reports and you do heart biopsies, you're going to see the name Seaport criteria. This was a group of US and European pathologists, including Joe Malachewski at Mayo here in Rochester, as well as Melanie Boyce here, who wrote the Seaport criteria over 4 years. I thought we had a terrible time with 2 years for the ACDP, but this was actually up to 4 years they were working on this one. And this replaces the Dallas criteria endorsed by their relevant societies in Europe and the US. If it's florid, meaning widespread diffuse myocarditis, look for its specific forms like giant cell, eosinophilic granulomas, call it severe. If it's not diffuse, look for clusters. 2 or more, it's moderate. 1, it's mild. And then this is the controversial part here. Step 3, they recommend a CD3 immunostain. We have not historically done immunostains in the US routinely. They are done routinely in 80% plus of European pathology labs. But this is now recommended for all patients with myocarditis on this is for biopsy, not whole heart specimens like autopsy. But if you have 15 or more, it's mild, 6 to 14 CD3 positive per high Farad field. It's this new category, SITUS, which is scattered increased T cells of undetermined significance. And then 0 to 5 is not myocarditis. This is now needs to be prospectively validated, right? So there's a lot of work that's going on. If you are interested, I don't show the data, you can go and look at the paper. There's a reason for these thresholds based upon analysis of hundreds of samples. And it's different. It's different than the old European, and this will replace European and US thresholds. So let's summarize. This is the management pathway intended for clinical use from the ACC. And the step 1 is think of myocarditis, because that's where a lot of people think, oh, coronaries are normal, we're done. No SCAD, it's not Takotsubo, it's done. But that isn't the case. After you've excluded that, you still need to hospitalize these people. I'll show you why. There's a 3 to 6% rate of progression to high-grade heart block or VT, even in the low-risk people. Multiple studies show that. And that's high enough that you need to watch them for a couple days. The duration of watching may be not known. And then triage, if they're low risk, cardiac MRI, if they're high risk, biopsy. And the biopsy in those people who are fulminant, who have requiring inotropes or mechanical support, is really in the first couple days. And I'll show you the European guidelines specify that. Then treat. And we're going to talk a bit about treatment for stage C. Obviously, guideline-directed heart failure and arrhythmia management. You want to do all the mechanical support that's necessary. And then once they get out of the hospital, follow-up. And both the US and the European documents say follow-up and echo and clinical visit within 2 to 4 weeks. And then in those people who are sicker, who have a significantly abnormal MRI at baseline in the low risk, you do want to see them back and repeat that at 4 to 6 months is the range. And the reason is that about 13% of those people, often with genetic cardiomyopathies or previously unsuspected sarcoid, will get worse. And if your delayed enhancement is growing, not getting smaller or stable, or if it's in the septum or the RV free wall is involved for like AVRC or sarcoid, then that's a high-risk pattern, and that may be developing beyond the first 2 weeks, right? You're maybe just catching the first episode of a DES cardiomyopathy, which will become apparent on the next scan. So there have been 11 registries today since 2017, large registries, single or multi-center, with both base of the pyramid general myocarditis and more severe fulminant myocarditis from Europe, US, and Asia. This is from a editorial Wilson Tang and I have in press at Journal of Cardiac Failure. And I apologize that it's not super fancy media support made, but I just did this. This was just accepted 2 days ago, so I just made it last night. But these are just the, if you hear this talk in a month, it'll be fancy. But if right now, so these are early ones, Itami, Lombardy Registry, and the Israel Sheba Medical Center. And what I want you to see are, these are, again, base of the pyramid, mild myocarditis. And the point is, in large, 300 to 400 plus groups, most of these are young, mid-30s, male, 70 to 84%, most diagnosed by cardiac MRI. And to put this and the other studies in perspective, lower ejection fraction, strongly predictive of bad outcome, as well as more extensive or high-risk patterns of late gadolinium enhancement. So you do want the MRI in those low-risk people. The overall rate here in uncomplicated was 4% at 5 years, and then in complicated was about 15%. So complicated means they develop or ventricular arrhythmias, high-grade heart block, or EF of less than 50%. So in the next set, so these are two fulminant cases that came out in 23 and just in September, and they're very different, right? So this is older. Number one, these are 40, 43. They're less frequently male. There are more women in the older group. You may, if you follow the literature, see that in Germany, US, and one other series I'm forgetting, that women have a higher mortality. Even though I showed you the incidence is overall, the death rates are higher in males at most age groups. Once you pass 55, the death rates in women exceed the death rates in males. And women are older at the age of presentation than males on average. So 30% in-hospital mortality, and again, 65% transplant-free survival, which means 35% died or had a transplant. So very, very different. So you're getting the picture. You can divide the group early on into the 10 to 20% that behave very badly and the 80 to 90% that are fine. And you can just get conservative management. This is just one example I didn't show. This is the most recent registry. This is from France. It's the largest, 803 patients, 82% male, 31 years old, 93% chest pain. So this is, of course, a low-risk group of people. And in the low risk, there was a 3.6 rate during the hospitalization of going on to heart failure, VT, or heart block. So my takeaway from this is that it validates. This came out after both guidelines. It validates what we said, is that you really do need to go in the hospital. You can't send these people home from the ER. You need to monitor them for a day or two to catch that 3.6% rate. Is this useful? This is good? Okay, we'll keep going. So, so now we're up to stage C, right? This is now, we're in the second half of the talk. We're transitioning to how do you manage generic myocarditis and the specific forms that are important that you might see once a year here or once every 2 years. But when you get one, it's really important to jump on it. So the guidelines, and this is completely aligned for both European and US, everyone says GDMT for heart failure and arrhythmias is equally relevant to the myocarditis population as to non-ischemic cardiomyopathies in general. Colchicine is also recommended in both the US and European with high-dose aspirin or nonsteroidals for pericarditis without heart failure. But if you have clinical heart failure, low ejection fraction, we avoid nonsteroidals. That's in the guideline. There's a bit of a difference here. Both the US and European documents say we don't immunosuppress routine mild lymphocytic, and we do recommend immunosuppression for giant cell, severe checkpoint inhibitor, eosinophilic that's not infectious, granulomatous, which in its idiopathic form would be usually sarcoid, and autoimmune means lupus-related or other systemic disease associated myocarditis. There's a difference that the Europeans do recommend, and you'll see here, viral assessment. If you end up with a more severe myocarditis that doesn't fall into a specific histological or clinical paradigm, that you go on to biopsy to identify active viruses. And that has not been typical in the US. Maybe less than 10% of sites do that. That's been quantified by the same group that did the Seaport criteria in a different paper. But it is common in Europe. It is common in Asia. And so it's something for you to know about, that you can send viral genome analysis. And if it's negative in the chronic setting, which is now more than 3 months of symptoms, then you would institute azathioprine prednisone or CellCept prednisone in those data. So what's the data for colchicine? This is the basic paper here. This is from Massimo Imazio in Italy, who's done a lot of work on colchicine and pericarditis. And this is his myopericarditis paper from about 1.5 years ago, showing that the rate over 4 years of recurrent myopericarditis dropped from 43 to 19%. It's a case control study, well done, but case control. And the Argo trial is prospectively confirming this in France. This is the way the guidelines read in Europe. Colchicine should be considered 2A level of evidence B. for myocarditis to reduce recurrences. And the duration is 3 months for the first episode, weight-based dosing, and 6 months for the second. So now we're going to dive into specific forms. The first is genetic. So we had a great conversation last night at dinner about these unusual, rare gene-positive patients who have recurrent myopericarditis. Kasia and I share at least one, if not several patients from this medical center with this clinical phenotype. And this figure I really like is from Perry Elliott and his group in London, showing that the most common gene for low ejection fraction is titin with myocarditis presentation. The most common gene for arrhythmia presentation is DSP down here. Probably not surprising since one's associated with other forms of cardiomyopathy, peripartum, et cetera, and this is associated with ARVC and other arrhythmogenic. And then there's a whole boatload of other less well described genes that have been described. And I would say this mirrors my practice. I see mostly desmosomal genes associated with ventricular arrhythmias and titin and BAG3 and similar RBM20s associated with low EF cases and risk of progression. And about 20% being positive if you're adult complicated, higher rates if you're a kid with presentation. Those are rare. And I'll just say we have another paper that's under review from sub-Saharan Africa, looking at over 700 patients who are genotyped for cardiomyopathic genes and had myocarditis or other forms of cardiomyopathy. And the pediatric group, there were 26 kids who had myocarditis presentation, had 0 positive genes. So I think that, as opposed to 44%. So I'll just say that this almost certainly has selection bias for places that can do genome testing. So what about DSP? We're going to focus on DSP because I think it's a very hot topic, no pun intended. This is a paper from Alexio Gasparetti when he was at Hopkins, looking at he gathered 1,000 patients as a cardiology fellow with pathogenic or likely pathogenic DSP variants, and 17.5% experienced myocarditis, right? So that's a high number, even if you take into account the bias of reporting bias. It's still a high number, and that the presence of a myocarditis episode in a gene-positive individual predicted future ventricular arrhythmias and myocarditis. This is the main figure that they had, and if you look at blue, yellow, and red, no episodes of myocarditis, first episodes and repeat myocarditis, multiple episodes, there was an incrementally increased risk of future ventricular arrhythmias or heart failure if you had 1 or more episodes of myocarditis. So that, I think, in the large, now that's not the first paper to show that. We also showed that in an older paper from 2022 in a smaller group of people. This is a big group of people from a much more diverse group. So definitely worth paying attention to. And it's important. How many people are electrophysiologists in the room? 1. Okay. Well, this is for you. So this is, and everyone else, just be patient. So in arrhythmogenic cardiomyopathy, early on, the mechanisms are different in the hot phases than the mechanisms in the late phases. So other papers from other people in Italy. This is from a figure of a paper that came out yesterday, looking at the histology both in mouse models and in human biopsy samples that Giovanni Pareto did, showing that in very early arrhythmogenic cardiomyopathy, you get an increase in space at the cell junctions, where specifically at the intercalated discs, you get this thickening, and then that thickening leads to a cellular infiltrate, which is the clinical myocarditis. That leads to cell death. It ultimately leads to interstitial and then finally large areas of scar. And so in the chronic setting, you get monomorphic reentrant ventricular arrhythmias classically, where in the early setting, you get more polymorphic. We treat early ventricular arrhythmias in active myocarditis with immunosuppression, typically, and then when they cool down, consider ablation. But ablation for hot myocarditis typically is not successful. So what kind of immunosuppression would be the next question, right? And so this is from Gasparetti's paper, and surprisingly, colchicine and no immunosuppression had the same impact in these patients who were treated during hot phases, where immunosuppression, which was a grab bag, largely prednisone-based with either Cellcept or azathioprine in most cases, but there was a lot of other stuff thrown in, had a lot less recurrent ventricular arrhythmias. And I think that's been based on this, and this has been our experience as well. So it obviously needs more validation and mechanisms, because we would have predicted that the colchicine would have worked at a lot lower toxicity, but these are the data. So let's move on to checkpoint inhibitor myocarditis. This is a patient of mine who died. He was at Mayo Clinic in Florida last year, and this was his heart biopsy. He had been treated for cancer with a checkpoint inhibitor, developed classic myocarditis, ST segment elevation, cardiogenic shock, died. This is one example. If you were to immunostain these, they'd be CD8 positive cells. And this is important because remember the very first slide I showed you, there were 1.04 million cases of myocarditis in the world. Well, there's a lot of people being treated with checkpoint inhibitors. There are 13 approved in the US as of December of a year ago. And if you estimate, based upon a conservative rate of 1 in 400 to 1 in 200 cases of myocarditis with monotherapy, or up to 1.3% if it's combination therapy with multiple checkpoint inhibitors, you're looking at over 100,000 cases of myocarditis, which would be 10% of all the myocarditis cases in the world, right? And I'm sure many of these are undiagnosed, but again, this is an important area that is growing. I've tailored this down to just 2 slides. The screening for both US and European recommendations is to do troponin and EKG baseline after cycle 1 and cycle 2 at least. Those are 2-week cycles. And then treatment is based upon severity of illness. If you just have a troponin rise, the Stanford data and others would say that you can triage to an observing area, hold the checkpoint inhibitor, trend the troponin. If you have a clinical syndrome, the rate of bad things happening, and it's a minority, right? It's maybe 10, 20, 30%, depending. But it's a smaller number, but those people they do need immunosuppression. Both US and European groups recommend at least high-dose prednisone for the clinical positive as well as the troponin positive, with monitoring in ICU if you have arrhythmias or heart failure, and then pretty high gun, intense immunosuppression. This is the figure from the European guidelines, which basically says class 1, hold checkpoint inhibitors. Notice the 24-hour triage at the top. It says you should be all over these people. You may not be treating them in 24 hours, but you should be looking at them, making a decision. Is this a sick person or not? And so then go through steroids to second-line therapy. This is a figure of what they recommend. I don't think there's any really good data to say whether Cellcept, mycophenolate mofetil, or these other ATG or more Campath, for example, a very powerful anti-CD52 molecule, have any comparative data. But certainly these and the JAK-STAT inhibitors have been considered, and people have published case series on them. So there may be more questions about checkpoint inhibitor, but we have 7 minutes left, so I'm going to focus on giant cell. This is the disease that is the reason I study myocarditis. When I was a 3rd-year resident, a young woman, 28 years old, was admitted to the CCU when I was on call, and she died of giant cell myocarditis. And at a time when there were no VADs, there was no mechanical circulatory support in the early 90s, and transplants were not consistently available. And so that's how I started this work, which ended up showing the survival difference in giant cell being much worse than lymphocytic, with an overall 90% rate of death or transplant. I'm happy to say that the outcome is better today, but this is only September of this year. A registry from Germany looked at all fulminant cases and they had 13% giant cell. They biopsied almost everyone. 13% had giant cell, which I think is representative of our experience and the Hopkins experience, and that another 10 or 12% had eosinophilic, often with negative peripheral eosinophil counts. And so they reported a 54% one-year mortality. Down at the bottom here, you can see that was the greatest, strongest predictor of death in their series, which means you should try to make the diagnosis. Do the biopsy early. In my own practice, I will call in the cath lab on Saturday if I'm on call and somebody has what looks like classic giant cell, progressive cardiogenic shock with ventricular arrhythmias, and that you need the path tech and the pathologist, because the 2 days makes a difference. And so how do you manage them? The foundation at the bottom is solumedrol, a gram a day for 3 days, and then a taper. Everybody gets a calcineurin inhibitor, cyclo, and now, of course, tacrolimus, which used to be FK506 years ago, is now taken over, in most cases, from cyclo. I think it works just as well, with pretty high trough levels illustrated there, and in the acute setting. And then if there's any intolerance, renal failure, other reasons why calcineurin inhibitors at those doses wouldn't be tolerated, I'm very fast to throw in either a CellCept or an mTOR inhibitor, like sirolimus. And so the future, I'll just touch on this. Javed Moshlehi, who's now, when he was at Vanderbilt, published this small series showing that both RNA-seq from biopsies and more recently from peripheral blood can be distinguished giant cell from other forms of cardiomyopathy. This is a slide he shared with me a couple months ago. We were on a phone call with his postdoctoral fellow, Grace Liu, and they have a well-established Lewis rat model of giant cell up here on the top right, where they give human cardiac myosin incomplete Freud's adjuvant twice. They develop a fulminant giant cell myocarditis. And in this, the point of this very busy slide is that abatacept, which is a CTLA-4 augmenter, it increases regulatory function, actually treats giant cell in isolation. So that's actually pretty cool. I was a little surprised because it takes a while to work, and I'm not exactly, I wouldn't have thought that it would work because you need a drug that works really fast. But in this case, it was surprising, and maybe it's something in the future. We don't have enough time to go into sarcoid in depth, but I wanted you to be aware that there have been 2 scientific statements. This is one we wrote from the ESC. There was a similar one from the AHA in 2024, and this state-of-the-art review that we wrote about the same time. A lot of the authors are overlapping, the recommendations are overlapping. The only thing I wanted to show you, because it's cool and it's new, is that in the European guidelines, electroanatomical mapping should be considered with a 2A level of evidence. See, for the one electrophysiologist in the room, maybe this will be relevant, but if you just do a blind biopsy of the RV septum, you usually miss granulomas. They're very focal. And so I'll show you a picture. This is from this August. This is a patient of mine, an older guy, who had suspected sarcoid, had ventricular arrhythmias, classic presentation on his PET scan. This was the area of increase of scar and fractionated signal way up at the base. If you guys do heart biopsies, imagine trying to curve that stiff bioptome to get all the way up without perforating the ventricle. Could be difficult. So this is what we did, and we described this before. We kept the sheath in place, used intracardiac echo, put a alligator clip on the end of the bioptome so you could visualize it on the CARTO map. And then with the sheath unmoved, moved the bioptome from the right groin all the way up to that exact place. You could see on the CARTO map that it was right over the area of fractionated signal, and then this was the biopsy. So he had sarcoid biopsy proven. Obviously, most people, 90%, have sarcoid elsewhere. You don't need a heart biopsy, but there's a small group that don't have it elsewhere. You should think of genetic cardiomyopathies as well. This is just one of the papers from Rochester showing the 95% rate of pulmonary or mediastinal sarcoid. So we're going to finish here with resume to activity. We wrote in our EDCP in February of last year, a year ago, yeah, it was just this 12 months ago, that 3 to 6 months was needed for time away from sports. That was based upon animal data. The group at Kim et al. 2 weeks later from also from ACC, said 1 month based upon data from athletes in COVID. And the Europeans went with the Kim data and said 1 month. So at 1 month, if with very mild cases, you can recommend return to sports with a class 1 level of evidence C for just expert opinion. And that's true for pericarditis and myocarditis in the European guideline. This is a paper I presented in Trieste, Italy in November, which was the primary results of the Archer trial, which was cannabidiol versus placebo. And you can see at the bottom, the combined endpoint was cardiac MRI, ECV, and change in LVEF. And it turned out we missed our primary endpoints, but you can see at the bottom right, we did have a substantial and significant decrease in LV mass, as well as intracellular and extracellular volume trending in the right direction. So this is hopefully going to go on to a phase 3 trial, still waiting on funding. That's new. And then the MITS trial is actively enrolling. They're about halfway through enrollment at 98 patients with 2 sites in the US, UCSD and Virginia, enrolling fulminant myocarditis. So if neither is particularly close to Minneapolis. But you could be part of this. I'm sure Enrico Amaretti would love it if you wanted to join. But this is a randomized trial of Solumedrol versus usual care. And that's it. Great.
Fantastic talk, Dr. Cooper. Thank you so much. 2 things that I guess I'm curious about. You talked a little bit about the, often genetic component, and often patients with uncomplicated acute myocarditis. Are you genetic testing all of those, or is it just the subset that have sort of more sophisticated disease or more severe disease? And then the second question I have is, do you see any hope on the horizon for molecular or blood test type diagnostics for cardiac sarcoid, which remains really challenging and frustrating to diagnose?
Absolutely, yeah. So the first one was an area of disagreement between the US and European documents. We came out with what was somewhat controversial, saying you should offer genetic testing to people with myocarditis without respect to severity. Europeans said it should be offered to everyone who has complicated myocarditis and considered in other cases. Definitely a different spin on that. What I tell everybody is there's a genetic component to some myocarditis. I take a family history. I said, do you have first-degree relatives with unexplained cardiomyopathy or died suddenly? And if it's cold, there's no signal on the history, and they're not adopted. And there's and they're uncomplicated. I don't typically go on. I don't advocate for it because it's low yield. But in people who have sustained and symptomatic ventricular arrhythmias in a new cardiomyopathy, I send gene panels now. In our lifetimes, what used to be $1 million test that you can get at any strip mall. So it's sending gene testing is checking a box in Epic, and $100. So I do it pretty routinely. Oh, and then I'm sorry. The second question was what do about
sarcoid diagnostics?
So there's there are new biomarkers that have been reported and not validated. I can send you the references. We are working on more general biomarkers for myocarditis in general, blood-based. I can share those data.
Thank you.
1, 2, 3. You go first.
Thank you so much. A very wonderful talk. Question for you in terms of arrhythmia management and myocarditis, AV block and ventricular arrhythmias. How do you approach timing of devices, be it temporary or permanent devices versus also wearable devices, be it life vest versus a loop recorder when you are managing such patients?
Yeah, so uncomplicated, I don't recommend life vests or anything other than clinical follow-up. For people who actually have high-grade heart block, it often reverses, right? If you have a viral myocarditis and they're treated and they recover, Often the temporary wire can come out, and they seem to do very well. I haven't always advocated a pacemaker early on in those people. It's a little bit different by cause. If it's due to sarcoid, the likelihood of ventricular arrhythmia is pretty high in the long run if you have any decrease in LV function or based on your pattern of LGE. So it's a bit tailored to the cause. For example, in giant cell, and this just came up this week, again, do you put in a primary prevention ICD in people who did not have an arrhythmic event, just a heart failure event, and then their EF recovers? And I do recommend that, although it's recognizing that not all the data sets are in the same direction. Some are neutral. But that's, so it depends on the cause, is bottom line. I don't, again, if you're worried, a life vest is not unreasonable for a couple months. Watch for LV recovery, and then look for the extent and pattern of delayed enhancement on the follow-up MRI.
Yeah, going back to the familial cardiomyopathy or the desmoplakin, which maybe my question is semantic, but you know, there has been confusion that has cleared about ARVC. I don't think we call it ARVC anymore. If you use the criteria, you'll be lost. We used to use LV involvement as a high-risk feature, and now we probably know that, you know, maybe it's not just fat replacement. But when you look at the desmoplakin phospholamban, who primarily present with LV involvement, and you explained very nicely how maybe inflammation is part of the pathological reason how you develop delayed in scar and so forth, and maybe inflammation is just a more accelerated phase of apoptosis that results in inflammation, and it's a high-risk marker, maybe. But how do you explain, we have few patients actually with desmoplakin hot phase, including a brother and a sister that presented at a very young age. At least in some of these occasions, the inflammatory markers are, again, I'm not an expert, but much less pronouncedly elevated than a troponin. So is there a difference between a primary inflammatory disease that ends up with a delayed enhancement and scar and might have completely different genetics than somebody who has primarily cardiomyopathic process and accelerated apoptosis and inflammation? Have you thought about that? I mean, is that question even relevant, or it's semantic?
Yeah, so I don't think we know. I think the core of the way I hear your question is, if you take the gene positive people who have an arrhythmia presentation or high risk features, and you follow them longitudinally, is their trajectory different than somebody who had a gene negative cardiomyopathy with the usual remodeling that we see without GDMT that used to kill most people? Now, the death rates have gone way down because aldosterone inhibitors and Entresto and all the great drugs we use seems to lower arrhythmia risk and lower heart failure burden. So the short answer is we don't know. The longer answer is my sense from all the data is that truncating variants of DES, although there's variable penetrance, on average seem to predict more recurrence, and the recurrence predicts more arrhythmias. That's my sense is, if you were to take a 30,000-foot view, that you'd have the predisposing factor, not the trigger, because you need a trigger too, like a virus or a bad drug or a vaccine or whatever, but the predisposing piece would still give you a higher risk, but it would be only part of the puzzle. It's also the nature of the trigger on top of the genetic risk.
I guess, you know, that's great. Guess my question also is the hot phase is just a marker where you need to look for familial cardiomyopathy, and it's a completely different disease process, and this is a marker of it. It's not a primary inflammatory process that ends up with scar. And the mere presence of a desmoplakin cardiomyopathy, even without inflammation, with delayed enhancement, would trigger an ICD, for example, conversation, because that's a high risk, regardless of whether they have inflammation or not. So it's like that hot phase with family history is, do they have familial cardiomyopathy? And this is a presentation of it, and that's a completely different risk profile than somebody with myopericarditis and delayed enhancement.
And I think what you're getting at is that if you look at the cardiomyopathy classification, right? It's not a perfect linear. It's a matrix. So you often get, after you work your way down all the algorithms, to two solutions. You get both familial cardiomyopathy and arrhythmogenic, gene positive, right? Or you get sarcoid and a gene at the end of the day. And so what do you do when your classification fails and you've got both? And that does happen. We've probably all seen it in more than one example. And I treat both. So I'm, in the absence of knowing what the right answer is, I tend to be conservative and say I'll use a conservative approach to both solutions. Is that fair?
Yeah, that's
Yeah,
fair.
the real world doesn't, the real diseases don't follow the buckets that we made for them, right? And especially if all these guidelines are made for very wealthy countries, right? So they don't work in rural Vietnam, right? So the next iteration is you have to make something that is globally relevant. And that gets to your question, when will we have a tabletop troponin-like assay for myocarditis that can triage in a rural environment without electricity, maybe, to a point where you can get that diamond, that 1 in 100 cases that needs to go to the referral center, right? This weekend, yeah.
I want to piggyback on Riot's question. I think he is talking about the similar patient, and that you are aware of as well, that young lady with VUS or desmoplakin. My question is, I have two similar patients that have recurrent myocarditis. One is gene negative, one is gene, VUS positive. And one has systemic inflammation together with her, and the other one doesn't. And the one with and I know that's what you were trying to say, is that how do you have all these hot spots in the heart with troponin elevation and symptoms of myocarditis, yet she had one episode where her CRP was higher, but who knows, maybe, she had a cold. But her pattern is no systemic inflammation. We measure CRP for these patients, whereas the other one, every time, her CRP goes up. And so is there...
Yeah, and so in the general answer to this is that inflammation in the heart is not well, and this is different than the pericardium, but in the myocardium, not well reflected in the peripheral system. For example, unpublished data, we studied 10 patients with giant cell myocarditis at Mayo who had a severe or moderate to severe eosinophil infiltrate in the heart, bright red eosinophils. And we looked at major basic protein, pro-major basic protein, and eosinophil-derived neurotoxin. And I thought, oh, this is so cool. Lots of eosinophils. We'll look at eosinophil degranulation products, and we'll find a new diagnostic test. 90% were negative. 90% were negative. And that's one example, by the way, of where you get the biomarkers in the periphery, either because of the kinetics of breakdown and release, or maybe the assay itself. And there's a lot of issues with assays and antibody interference and inflammation that you might have false negatives. So bottom line is that's a general answer, but I think it's relevant to your cases.
And one more question is about GDMT. Just one more, GDMT.
Yeah.
Do you use GDMT in patients like this who have normal ejection fraction, but a lot of IgEs? And if you do, what do you use? Because, it's hard to put them on all four. If they're young people, it's even harder because their blood pressure is low. And is there any data to support it?
There are some data. So if you read carefully the 90 pages of the European document, they do have for beta blockers for acute myocarditis, regardless of ejection fraction, a recommendation, it's a 2B or 2A, based on Valentina Puntman. Oh no, it's, I just forgot the author, but it's a German paper from 11 years ago that was in virus-positive, biopsy-proven myocarditis that it helped. And sicker group, okay, if you're getting a heart biopsy and you had viruses, they were all virus positive. So that was the basis of that recommendation. So in a little bit, there's some data in mice, and all of these are inbred mice who have horrible myocarditis. carvedilol works better than metoprolol, more anti-inflammatory effect acutely. In the absence of data, outside of animal models, which maybe are irrelevant, I typically, if somebody is stone cold normal, I tend to not start an ACE inhibitor or beta blocker. On the other hand, if somebody has an EF of the low 50s, certainly high 40s, I probably will do, even a young guy, at least 3 to 6 months of low-dose carvedilol, 3.125 twice a day, especially if there's tachycardia. There are many reasons why tachycardia, but that might be a reasonable low-risk intervention that could have potential benefit. And then I tend to not go for aldosterone inhibitors or SGLT2 inhibitors. If I do add a second agent, it would be ACE-ARB, in that space. But my first go-to, based on the mouse data, is carvedilol. But you've been waiting a long time.
Thanks. So we frequently get consults in the outpatient setting for patients on checkpoint inhibitors where they get serial echoes and you're seeing a change in their global longitudinal strain on there. So how do you approach those patients?
And first disclosure, I don't work in cardio-oncology clinic, although I see them when I'm on hospital service. Obviously, we all see them when you're in that space. But I would take it GLS is not specific for one disorder, but we and others have published that in mild myocarditis, it's more abnormal first before you get lower.
Like their ejection fraction hasn't changed much yet.
So I would take it as a risk marker, and if it was accompanied by an increase in troponin that looked substantial, certainly I'd hold the checkpoint inhibitor. Obviously, that's puts you at risk of recurrent cancer, but you'd have to. It would be an area of shared decision making, and I don't know the literature on GLS and checkpoint inhibitor, mild checkpoint inhibitor myocarditis. Great paper from Stanford this year. They looked at all of their hundreds of checkpoint inhibitor myocarditis patients. About 10 or 15% were symptomatic, and they had 3 or 4 or 5 times the rate of adverse events. So it was they felt the point of the paper was that you need to triage people like this by analogy with an elevated troponin. Maybe this is like an elevated troponin. You need to look at them carefully in clinic and say, is there any sign, rising NT-proBNP, for example, that's tracking in the same direction? Yeah.
Thank you so much, Dr. Cooper. I continue to learn from your fantastic talks over the years. So for GCI, I treat a lot of extracranial GCA patients, not necessarily with myocarditis. Do you screen for myocarditis in patients with extracranial
GCA? Oh, yes. Yeah. No, I don't. So for GCA, for not Takayasu's, but for giant cell arteritis, in the older population, you do get large artery involvement, clearly ascending aneurysms, lesser degree of aortic aneurysms, intrarenal. But I haven't seen a lot of myocarditis. It's an older population with hypertension and comorbidities. I still think like rheumatologic disease in general, there's going to be a higher rate of atherosclerotic events. Cardiovascular events in general will go up. Most of those will be the usual thrombotic, atherothrombotic stuff. And then maybe there's an element of inflammation thrown in that makes it, myocarditis. I've not seen that. To be honest, most myocarditis that I see is lupus. And that's tough, because if you see these people, the lupus patients are often on Plaquenil, and you don't, if it's more chronic, you don't know, is this a low-grade lupus, or is it Plaquenil cardiotoxicity? That's every year that comes up once or twice.
And do you use any tocilizumab for GCE myocarditis? I didn't see any kind of data that you listed for tocilizumab, interleukin-6 inhibitor, because we use it for GCA, arteritis, and aortitis.
Yeah, I have not seen the IL-6. Well, I'm sure they're mouse models, but in clinical, like giant cell myocarditis, no. There's one paper with rituximab. There's one No. No. In general, the answer is no.
Yes, thank you, Dr. Cooper. We do have just two virtual questions from the webinar folks. The first of which comes from Dr. David Lin, and he's asking, does troponin elevation in pericarditis necessarily mean myocarditis as well? Most CMR assessment does not show myocarditis. Also, troponin elevation in pericarditis does not affect prognosis.
Sure. I've taken elevated troponin in pericarditis to mean it's a cardiac source. And there are studies, 2 papers out, showing that the fat-associated FALCs, fat-associated lymphoid clusters in pericarditis make anti-myosin heavy chain specific T cells. So they generate autoreactive T cells. So there's a molecular mechanism for that, aside from just being next to the myocardium and killing, incidentally, myocytes. I think the spatial resolution of MRI is good, but it's not at a microscopic level. So I would probably say it is myocarditis. Does it clinically affect you? Historically, we've said I'm a bit more conservative going back to sports, even though I know the Europeans said that pericarditis with and without troponin elevation, we would treat with similar exercise restrictions. I've been, based upon theoretical arrhythmia risk, more reluctant to have people go to competitive sports if their myocardium's involved. Because where pericarditis, you get recurrent pericarditis, which can be managed. With myocarditis, you can get sudden death, which is tragic.
Yes, thank you. So the last question comes from Dr. Nick Burke, and his question is, does everyone with chest pain, mild troponin elevation, and a normal echo need a cardiac MRI?
Oh, great question. You probably saw our editorial in JCF this week. So the answer in the editorial is no. That in low resource centers that you have to triage your resources, and you can't be indiscriminately using the rare MRI or biopsy for low risk people. And so I think that, and there's a paper coming out of Sweden, which the editorial is about, that will say something similar, that the outcome that you can triage people at high and low risk based on echo features, and that the outcome with MRI in the Swedish group didn't vary. Now, it wasn't that big a population. And there's a lot of data that MRI patterns are useful, although much of it is from Italy, not all of it, where there's more genetic cardiomyopathies. But the bottom line is, I still rely in this high resource world on MRI for risk stratification. And the more abstract question, is it always needed, is probably no, but I'd adjust that based upon heavily on the clinical and imaging risk profile.
Thank you.
Thank you.